Thank you. Good morning, everybody. It is a complete pleasure to be here to share some of my insights with you. They're probably a little bit broader than giving you any of the answers. So I'm just going to. So again, I work at UCL in London and started looking after patients with osteosarcoma probably about 10, 15 years ago. And as has been said, not a huge amount has changed. I suppose there's some reflections along the way, and probably a lot of learning about how we make progress really in terms of trying to identify new targets, but also how can we really solve the problem of integrating some of these treatments into the care that we give patients. So just to start with a little bit of background, sorry, let me just go here. Right, so first of all, background, I think there are a few points to talk about this. So we all know that this is the most common primary bone tumor found in adolescents. It's about nearly 5 per million in children and teenagers, and is a great cause of death in children. But there is this second peak in older adults, and it's something that we really mustn't forget about. You can see some figures on the right there, that over half are under the age of 25, but nearly 40% of patients with osteosarcoma are over 40 years old, which does have great implications in what we do in terms of managing them. We all know that the most primary sites of osteosarcoma around the knee, the femur and the tibia being most common in the humerus, but that does change with age. And as you can see on this graph on the right, as patients get older, they have a higher incidence of axial tumors and tumors in the higher skeleton that may make management more challenging. We know that osteosarcoma is most commonly metastasized to the lungs and to the bones. I wanted to just touch a little bit on the etiology and the genetic predisposition of osteosarcoma, because again, this is also something that we're very well aware of in our patients. We know that it can run in families with Lemvatinib and those with RB mutation. It's also associated with a number of syndromes, but I think we've to date underappreciated the extent of how genetics influences osteosarcoma, which is not so surprising in patients with cancer at a young age. So recent study looking at over 1,000 patients with osteosarcoma showed that over a quarter have a potentially inherited predisposition gene, and nearly 20% of those are an autosomal dominant gene. And also in that study, they showed that nearly 5% of patients had mutations of TP53 in the germline, many of whom did not necessarily have family history. So I think that's just something that we need to bear in mind, that is an unexplored field and something that we need to consider in terms of diagnosing and assessing risk for patients with cancer. Just back to the pathology, we always put a pathology slide on. We know that you need to see osteoid in the pathology to diagnose. We also know that there are multiple subtypes of conventional osteosarcoma, but that morphology does not impact the treatment. We kind of understand that chemotherapy doesn't quite work the same in all of these, but we don't understand how this integrates with the biology. And unlike many other cancers now, we don't subdivide our treatment according to pathology at this stage. So I'm just going to go through the general management of osteosarcoma and then come back to the more interesting parts, I suppose. I think we all know here that osteosarcoma is difficult. It requires complex multimodality treatment and the input from expert multidisciplinary team. In the UK, we have developed specialist centres. There are only 5 centres in England that do surgery for osteosarcoma or for bone sarcomas, which we believe is integral to improving outcomes for patients. We also know to cure a patient, you need complete surgical resection and chemotherapy. I just wanted to take us back a little bit to right back in how did we know about the impact of chemotherapy? And I suppose, again, reflect on how difficult the journey has been since that time. So this is a paper that was first published in 1986, essentially showing the difference in event-free survival or relapse-free survival in patients who received two-drug chemotherapy. And it was only 50-odd patients. And here you could see the survival was from 17 to 66%. So remember that number, 66%. And since that time, many systemic therapy studies have been performed aiming to improve that number really and that outcome. Prognostic factors, which I'll come back to, relate to age, primary site and stage, but also response to neoadjuvant chemotherapy. So we understand that patients who respond well to chemotherapy when the tumor is resected have a greater than 70% 5-year survival, but those with a poor response is really less than 50%. So this is a very important prognostic factor, and something, of course, that was explored in the EUROMOS study, which most of you, I'm sure, are aware of, that was looking at the impact of changing chemotherapy based on based on response to chemotherapy, to map chemotherapy. And those with a good response were randomized to maintenance interferon, and those with a poor response were randomized to see whether the addition of 2 agents, hyphosphate and Atopicide, would increase outcome. And this demonstrated global collaboration was possible. So it's really important to note that this was possible. This recruited many centers across the world, including the US and Europe, and some further afield, and recruited more than 2,000 patients from 17 countries. I think the challenge, as you all know, was that this really didn't improve outcome for patients. Neither of those questions improved the outcome. I think we did learn many lessons from this. So first of all, in the good response, the addition of interferon, it did not improve overall survival, event-free survival. What we also understood was that it was challenging to randomize patients to maintenance treatment that was weekly at the end of long protracted chemotherapy. So many patients who were registered and randomized did not actually start the treatment, and many of them stopped early. On the other side, randomization of patients to the addition of 2 extra drugs also did not improve outcome, but did improve toxicity. And so I've put in big letters here, MAP remains the standard of care chemotherapy for patients under the age of 40, which I'll come back to. I also wanted to touch on mifemertide, which again is so this brings us into the immune arena. This drug stimulates monocytes and macrophages, supposedly to attack osteosarcoma cells. And this was an important study looking to see whether it improves outcome. What's happened in the event is that the data is somewhat confusing. The study also added ifosfamide to the same chemotherapy with some differences in doses across the way. The first analysis did not show any improvement in outcome, so the drug is not licensed by the FDA. However, a later analysis looking at these survival curves here, there was an 8% improvement in the whole group. But as I said, there was sort of complex statistics and a potential interaction, and the patients who received ifosfamide actually did worse than those who didn't. So we're now in a bit of a quandary about what this means and what do we call standard of care chemotherapy for patients with osteosarcoma. The drug is available in some countries in Europe, but not all of them. Many people believe in its effects, many do not, and particularly many of the scientific groups feel there's more data required to use this drug. We have it available in the UK, and we see some quite differences in practice about who is using it and who is not. So I'm going to come back to the standard of care. I just wanted to touch on a little bit about the age. So this is something that I've been really interested in and feel is really important in how we consider age in the treatment of osteosarcoma and how it impacts the care. So we know more and more, well, we've known for a long time that osteosarcoma outcome is poor when you get older. Why is that? Is it because of the treatment, or there are many factors involved? Recently, there is an analysis done of the Euromos cohort showing that age is an independent prognostic factor. So here's a Cox model for event-free survival, showed that children do better than adults and adolescents. So adolescents and adults do not do as well as children. Katie Janeway published children's oncology trials also showing that reduced outcome in adult patients. But when you get to the older adults, these over the age of 40 or 60, there's really very little data and very few clinical trials been done. So here's some data that we collected showing a good 20-30% difference in outcome patients with over 40. And if you go over 60, the outcome is very poor indeed. And what are the challenges facing older adults? As I said, alluded to earlier, they have a higher proportion of pelvic tumors, so more likely to be inoperable. There's a proportion due to second malignancies due to radiotherapy and Paget's disease. Craniofacial osteosarcoma, again, is not well understood, and chemotherapy is not very well defined in there. And then also, ultimately, there's a challenge with chemotherapy tolerance and response. And so I've just put a slide up of the first line practice of treatment of osteosarcoma, which depends on age, of course. And I think this is something that we have to come back to, is if we're designing new clinical trials, what is the standard of care for patients? The majority of Europe do use MAP chemotherapy. In France, they also use 3-drug, but in younger patients, no anthracycline. In older patients, they don't use methotrexate, so that's over the age of 25. In Italy, they're still incorporating ifosfamide and mifemertide. But what about in the older patients? The tolerance of methotrexate is challenging. We use 2-drug chemotherapy. Eurobos was a clinical trial looking to incorporate ifosfamide in lower doses of methotrexate. But some challenge to give and challenges in determining where we go next. So I think Dr. Tiwawi introduced us, said this same statement, and this plateau really highlights the need for a novel approach to research. So moving on then, where do we go from there, and are we making any progress at all? So onto the relapse setting, we know that patients who relapse have a poor prognosis. There are some prognostic factors, including your time to relapse. If you relapse over 2 years, you do better. Patients with lung metastases also do better. I just wanted to put the note in there about surgery. Resecting lung metastases can cure patients with osteosarcoma. So that is something that we always consider in patients who have a reasonable disease-free interval and a smaller number of metastases. However, there's no standard of care for therapy for these patients. The active agents, as discussed earlier, are ifosfamide and Atopicide, which is probably where we go to as our second line treatment. Gemcitabine and docetaxel is also active, with a retrospective analysis done across a number of centers, showing a 4-month progression-free survival of about 46%. So I've just put that in there as a sort of baseline from which to consider how we make progress. So the Children's Oncology Group looked at 7 clinical trials of patients, of new agents of patients with relapsed osteosarcoma. And this is what they found. They found that there was a 12% progression-free survival rate at 4 months. So all these clinical trials were negative over the course of 10, 15, 20 years. But what it did allow us to do was set a bar for what is deemed an active agent for new therapies for osteosarcoma. So 30% progression-free survival rate at 4 months is deemed active and gives us a good benchmark to look at new treatments. And so the major class of agents that really has been coming to the fore are tyrosine kinase inhibitors. Here is a table summarizing many of these. There are a number of studies and more coming through. And so I'll just go through these in a little bit of detail. But as you can see, I've highlighted the progression-free survival rate at 4 months. You can see across these that really it's hitting that bar over 30%, but the median progression-free survival is not really very much longer than that. Okay, so these drugs have activity, but they clearly do not offer the solution for us. Just to unpick these trials, we also have some other evidence. 2 of these trials with regorafenib were randomized trials with a placebo. So again, providing additional evidence of activity. I think interestingly, you can see that in the placebo arm, the progression is only one or 2 months. So we know how aggressive this disease is when it relapses. We also good to note the age of the patients for treatment. So these are mainly adults that have been that were treated, apart from the Lemvatinib study, because that was a pediatric phase 1. So just showing that older adults can tolerate these drugs without a problem, particularly, but not necessarily getting the data in the younger group. But what's happened since that time? So we know that TKIs have efficacy, but a big question is, how do we integrate this into our care to improve outcome for our patients? So the first study that has attempted this and has now been published was a phase 1 study of adding Lemvatinib in combination with Hyphosphate and Atopicide in patients with relapsed osteosarcoma. So this is published just last year, and here it showed that the progression-free survival rate was at 4 months was 80%. So we can see that, of course, this is non-randomized, but we can see that there appears to be a prolongation or improvement of getting to that bar, and the median progression-free survival was 8.7%. So this has been translated into a randomized phase 2 study for patients between having Hyphosphate and Atopicide plus or minus the TKI. But what's going to happen next with the TKIs? And of course, this is what you really want to know. And we don't have the answer for you yet. What was really fascinating and a wonderful opportunity was a meeting set up by Accelerate, which is an arm of the ITCC, inviting the European Medicines Agency and the FDA to come and have a discussion about how we translate or develop TKIs in bone sarcomas. The discussions ongoing and the studies in development really were talking about how can we incorporate these drugs into first-line therapy. We know that MAP chemotherapy is extremely toxic. Is that possible? But there does feel that is what is needed if we think that patients can continue and put up with that toxicity. There's also a question about introducing this into maintenance treatment, which feels like an easier win in some ways. It requires a lot of patients to be able to do that. And then also some considerations about other combinations. But what also came out absolutely integral to this was the importance of biomarkers in understanding who's going to benefit from this. And it's interesting, and I'm sure many of you involved in things that go on for many years is treatment may be identified through wonderful science, but this way, as many other things, we've got the efficacy, and now we're working backwards. There are a number of these TKIs. Do they all work in the same way? They've got different spectrums of activity, but how really do we find out which patients are going to benefit? So the discussion is about clinic models. Do we have the appropriate models to do this, and how do we test those combinations? So I'm not going to go into detail about that, but just I think it's important that we mustn't forget the biomarkers, because there are many other new agents that we've tried and failed, namely IGF inhibitors in Ewing sarcoma, because of the lack of understanding who's going to benefit. But what about potential other potential agents? Now, of course, this is where you're on the edge of your seats, and I'm afraid I'm sorry to disappoint that there's no magic answer for us today. I think again, there's, just reflections on this. The genetics are still poorly understood, and with such significant heterogeneity amongst patients. We know that TP53 mutations are very common. CDNK2A and RB would probably be the hallmarks of it, but also there's such complex rearrangements in these tumors. And the epigenetics too is not we know impacts on the on outcome, but how do we untangle all this to really get to that personalized care that people talk about? And again, I don't have the answers for it. I think I'll come back to it, but of course it's about integrating data is the only way that we're really going to help our patients. The other aspect that has been talked about over many years, again, in the interest of time, I can't say too much, but lots of people have been talking about BRCA and osteosarcoma, and are they sensitive to PARP inhibitors? There are different methods of exploring this, and there are other potential mechanisms of PARP sensitivity. I'm just putting up 3 studies here because there was quite a lot of interest about trying to get PARP inhibitors into clinical trials, but we have not concluded that there is BRCA in osteosarcoma. So I do not think that we are ready to put this into our clinical trials. And just a final thing, that in our institution, we've demonstrated there's a therapeutic vulnerability to PARP inhibitors in RB mutated osteosarcoma through a completely different mechanism. So there's definitely something in there, but how do we translate it into benefit for patients? I'll come back to that finally, but just to mention immunotherapy, because everybody wants to know about immunotherapy. Single agent checkpoint inhibitors are not active in osteosarcoma. We know that the macrophages or the myeloid system is more dominant. And again, I just have to say that work is going on to better understand the potential impact of combination therapies. And there is a clinical trial of a PARP inhibitor and an immune checkpoint inhibitor in pediatric patients with solid tumors. So that's an interesting combination. But again, I don't know whether the science really matches up to that question. So that's something that we'll have to come back and see. So just to conclude, we have poor outcome, poor prognosis. We know the TKIs work, but really still don't understand the biology. So collaboration is the only way, and correlative studies to improve that. My iconic study was mentioned, which is what we're doing in the UK, but in fact, we need wider collaboration than that. And so this is just putting up as a final slide, really, a new European consortium that has been developed, fighting osteosarcoma through European research. This is led by Nathalie Gaspar, which has multiple work packages and multiple partners, really trying to bring work through the biology and molecular profiling to clinical trials based on the relapsed and newly diagnosed patients, but also thinking about that local therapy and quality of life that is so important for our patients. So thank you. I'm going to end there. Again, I don't have all the answers, but hopefully in the next few years we can shift the paradigm really by just bringing all that data together. Thank you very much.
Thank you very much, Sandra. Indeed, it was a great talk. And I would ask Dr. Amita to ask a few questions.
Thank you, Dr. Strauss. Truly wonderful talk, summarizing the state-of-art management and also giving us a flavor of what the current research initiatives are showing or not showing. In the interest of time, I'd just like you to comment briefly on 3 specific areas. The first one, the tolerance to Lemvatinib, with concurrent chemotherapy, especially if you are using ifosfamide. Second, any comment on the role of proton and carbon ion therapy for unresectable disease? And thirdly, prospective clinical collaborative research is just coming of age in India. So do you have any suggestions for us in LMIC as to where our efforts could possibly be directed?
Okay, thank you very much. All great questions. So the first, in terms of tolerance, so interestingly, that combination was quite well tolerated. You do see the toxicity from chemotherapy, so the febrile neutropenia mainly, and you get the toxicity from the TKI, but it was tolerated at normal doses and really felt possible to take forward, which also has given some information about whether we can do the big challenge and try and add it to MAP chemotherapy. But it needs
Doable.
specialist care, and I think that's one of the challenges when you roll this out to a larger population. The second about PBT, yes, and apologies for not fitting that in actually, because that is massively important. There's early data that shows that PBT may allow local control for patients with inoperable osteosarcoma. I think the data from carbanions is stronger than PBT. In our experience of having had a few patients have PBT, it's not curing the patients, but it can allow local control, which is such an awful problem for these patients. So certainly that's important. And then thirdly, prospective and collaborative efforts. I mean, having been doing this for a little while, and everybody will believe this, I was just, I mean, just to go back to your previous speaker who showed what amazing work that you'd been doing about collecting your data across your patients. I mean, you have such a vast population. I think it's that collection of clinical data, imaging data, and biology that is going to help us get to where we need to with artificial intelligence. Machine learning is lovely words to bandy about, isn't it? But that needs investment and funding, doesn't it? And what we're doing, certainly in the Foster Consortium, is really trying to bring all these things together. So that would be my recommendation, of course, and it's about coordination across the country, and then opportunities to link with things that are going on across the world.
Thank you so much for a wonderful talk. I'll hand over back to the organizers to take the session forward.
So thank you everyone, and thank you Sandra again, and thank you chairpersons, thank you Amita for a wonderful and very crisp moderation. So in the interest of time, we need to move, otherwise this session will go on and on.